So, hello to everybody. I know that many of you in this room, and it is absolutely delightful to be able to see you in person. I have to say, I found that last year speaking to my little laptop in my dining room and not being able to see any of you, I do apologise if I rambled at times. So it is lovely to see everybody back. And what I'm going to do over the next 20-30 minutes, I have to say, John sent me a very strict guideline of 20 slides, no more than 5 graphs, and I think I'm almost sticking to that. I'm really just going to cover, it's not going to be exhaustive, so many things might come up in discussion, so please feel free to ask me anything at the end.
That little thing there that's on the screen, that's subtitles. So, in case you're wondering what...
No, I'd clocked that. I think, I just thought, so do keep me technically right as well. So yes, what I'll do today is really just run through really a kind of summary of the key things that have really made me think over the last year, what is new and what's informing our practice and our discussions with patients. And as you'll see that I think we're in an improving place, we have increasing choice and finding our way in how to navigate through the different choices at first line and beyond is a complex thing for us as haematologists and yourselves, and for us to work together. So I really base my talk on the current updated British Society for Haematology guideline, which was published earlier this year. I have to say that whenever a guideline is published, obviously the data continues to accrue, so I will update in a few areas from the key trials that have updated at the more recent meetings, and some areas I may speak about my own personal opinions as to how I use the guidelines in practice, and some of what I say may be my own opinion, hopefully based on the showing you the data to back that up. So hopefully we'll generate some discussion as we go through. So any of you who were able to link in last year will have seen this slide, really just highlighting the change that has happened over the last decade in the choices we have available to manage CLL. And we can see that up until the early to mid-2010s, there was very much a drive. We had obviously the addition of rituximab to chemotherapy now a reasonable length of time ago, and then the drive was on looking at less toxic, less intensive chemotherapy backbones to use with and differing antibodies with the introduction of obinutuzumab. However, really since about 2013-2014, all of the new SMC approvals have been approvals for the newer targeted therapies, which we'll focus on today. And as you can see, we have had a number of approvals through the years, and we'll touch on how that has impacted our practice. I think, as John was mentioning, that it is very important, and I think it's the first time I've been introduced as a foot in the door, but I don't mind that, because I absolutely agree as well that it's important that when we're looking at access to the new therapies within the United Kingdom, that as we've been going through the COVID pandemic, there has been slight variations in access, mainly in that south of the border there has been the ability to access Venetoclax and obinutuzumab for younger patients who otherwise would have received FCR, and that has been available to through the Cancer Drugs Fund, and until May of this year not been available in Scotland. However, through the pandemic we have had COVID guidance which has allowed us to use BTK inhibitors, ibrutinib, and more recently acalabrutinib. So there have been variations in practice, and I'm all very much believe in equality of access, and thankfully that is becoming more matched up. And so as I mentioned, what I will try to do is run through the key points that have been highlighted in the updated BSH guideline for the management of CLL, which has been written by many of my colleagues in the UK CLL Forum and BSH Writing Group, who have done really an excellent work. And if you have trouble sleeping, this is freely available online on the BSH website. But I'll really just try and distill the changes, and we can discuss the implications of that as we go through. What the BSH Guidelines Writing Committee have come up with is an algorithm as to how we manage CLL. I think you'll probably agree with me that this looks a bit complicated, and it is, I think. I think the main points I'd want to highlight from this is that at the top, there remains one of the first decisions that we all have to make when we sit down in a clinic making a diagnosis is to run through and say, what do we do about this? Is there an indication to think about using any of our targeted treatments? And it does remain that, I have to say, and I'll run through the criteria for treatment, but in the absence of disease progression, bone marrow failure or symptoms, the standard of care remains active surveillance at this point in time. And I have to say, and I hope, and there may be many of you listening in to this presentation who may not need to listen to much of this stuff, because it may be that we might never need to actively intervene in CLL, because we know it's a heterogeneous disorder and sometimes it can sit in the background. And we'll run through what does that mean, what is active surveillance. We've kind of moved away a wee bit from speaking about watch and wait to actively running through what does that entail, because there are a number of things we need to be on top of when we are following up patients with a diagnosis. In terms of going through this algorithm, things to highlight are when we're looking really at frontline or beyond therapy, is that when we go down to the, obviously, that's the pointer. I'm glad I worked that out before the end. Okie doke. So when we're going down, and I'll run through and spend a good bit of time looking at all of the things we need to consider, both clinical and disease-related factors, when we're then going down to choose therapy. You'll see, looking through either frontline therapy or second-line therapy, there's not much chemoimmunotherapy there anymore. And that's not to say that was not good treatment, because many of you listening today may well have had chemoimmunotherapy, and clearly that was standard of care at the time and better than what had gone before. However, there have been a number of trials that have shown that compared to our many of our chemoimmunotherapy regimens, that targeted therapies have equal, if not superior, remission rates and duration. So we can see that obinutuzumab and chlorambucil and rituximab and bendamustine really have come out and are specifically not recommended in the frontline setting. And indeed, the place for thinking of FCR, which for many years has been the backbone of CLL therapy in the younger CLL patient requiring treatment. There is a specific description to specify that we should only be considering FCR treatment in a very particular set of patients where we don't see abnormalities in the TP53 gene, and when we look at the immunoglobulin heavy chain gene, which we know around about half of patients with CLL, the B cell receptor immunoglobulin heavy chain gene can show mutations similar to those that are developed during an immune response, and some are more related to a kind of naive B cell that tends to respond to signals through the B cell receptor a bit more. So we do know that a number of patients with mutated IGVH CLL may have durable remissions following FCR, that in some cases may last a decade or more, and have led to some speaking about whether this may represent a functional cure. As we go through, we'll look at a bit of data showing how our targeted agents might stack up against that, and where we may consider that. But I think the main point I want to draw to your attention is that really And for most patients, we have choices, both at first line and relapse. And it's not a clear algorithm to say, if I have this cytogenetic abnormality and mutation status, I should definitely have this. There are a number of factors we consider, and I think overall this is a very good place to be in. So running through, I'm not sure how many people listening may have had a recent diagnosis of CLL, but running through from the beginning, it's more often than not now that we often make a diagnosis of CLL incidentally on a blood count that is done for an entirely different reason that comes through our lab, and we pick up a raised lymphocyte count, and then we will then trigger and send our sample over to our local cell markers lab, and we can make the diagnosis on that. Often we do see a number of people who do come along referred through the GP or presented with enlarged lymph glands, but often we make a diagnosis incidentally, so usually making a diagnosis is fairly straightforward and quick. So when we will see people up in clinic, we will look at the rest of the blood count, because we know that up to 1 in 4 people with CLL can develop autoimmune complications, either autoimmune red cell hemolysis or indeed ITP. So might come along, and I've made a diagnosis in a patient who just had blood count and had 1 platelet, which was not as many as we would like, and we quickly sorted that out. Really, from the outset, we are starting to thinking of the long-term disease course. We are wanting to obviously take a full history as what we do as doctors, but the reason to do that particularly, and from the outset, we're starting to think about particular health conditions and particular medicines that might influence our discussions if treatment is required as to which route we may take, and I'll go through that in a bit more detail. We obviously want to examine to see if there are any palpable lymph nodes. Always after a first appointment, we back that up with some written information, and then our the booklets we use are really very well written and very comprehensive, and then can sometimes generate, what else do I need? Do I need all of these additional tests at outline? Could ask, do I need to have my immunoglobulin heavy chain gene and P53 gene status checked at diagnosis? In terms of P53 gene mutation, we see that for patients needing first-line treatment in about 7 in 100 people. If we pick that up right at diagnosis and there's no other indication for treatment, then it will still not influence our management right at diagnosis. So we don't always check that right at diagnosis. And it can change over the course of disease. So we always check it prior to each line of therapy, so prior to first-line therapy and again at second-line therapy, because these cytogenetic and genetic abnormalities can be acquired over time. In terms of immunoglobulin heavy chain mutation screening, it can be checked earlier in the disease course because it doesn't really change. But again, it would not change management outside treatment. So as the BSH guidelines do recommend, when treatment is nearing, and in most cases that we have a period of at least a month or 2 where we can start to discuss treatment options and the fact that the time for treatment is nearing. And it does take around about 4 to 6 weeks for these tests to come back. So there's usually enough time when it's clear that the disease is starting to move that we can send these tests off at the time that we're starting to speak about treatment options. Should everyone have a CT scan? Again, not always at diagnosis, unless sometimes CLL can present more in the lymph nodes with not many cells in the blood, and we call that small lymphocytic lymphoma, so we're more likely to do a CT scan at diagnosis there. Some treatments, particularly the Venetoclax-based treatments, mandate a CT scan to assess the lymph node size when we're assessing the monitoring required when we start increasing the dose escalation phase of starting Venetoclax to measure the risk of upset to the kidneys, what we call tumour lysis syndrome, when we start breaking down lots of cells. Prior to any line of treatment, we always assess for prior exposure to bloodborne viruses. So indications for treatment, I have to say it's probably about 8 years ago since I first was invited to speak at this meeting, and I have to say this has not changed. It's about the only slide that hasn't changed. The things that we look at, when we look at a blood count, as I've touched on, there can be a number of causes for low blood counts. Whether it is autoimmune, we always need to think of that. But does it just reflect that there's a few more CLL cells that are building up in the bone marrow or accumulating in the spleen, both contributing to cytopenias? And once the haemoglobin starts to reach 100 or 10 grams per decilitre, or platelets less than 100, then it is an indication that we should be starting to think about treatment. Obviously, if there are very large lymph glands that are causing you bother, we obviously want to do something about that. And then looking at the lymphocyte count, we don't have a set lymphocyte count that we will say we need to start treatment once your lymphocyte count is greater than 100. We look at the rate of change, and generally a 50% increase within a couple of months, or a doubling time less than 6 months, is a clear indication that the balance of cell turnover is stacking up towards disease progression. Again, we wouldn't be too troubled by about a lymphocyte count that had gone from 5 to 12, so there is an element of that, and we try and consider this all in the round. Where we do see autoimmune complications, generally we would manage that with immunosuppression, and that would be another talk in itself. But suffice to say, if we have patients who are standard first-line treatment, steroid therapy is not settling down, autoimmune hemolysis or ITP, then we know from experience that we need to treat the underlying cause, because these secondary autoimmune phenomenon are not directly driven by the CLL cells, but more the immune dysregulation that arises from the CLL cells being there and manipulating the normal lymphocytes. And we also always ask in clinic about any disease-related symptoms. Fatigue, and we need to try and tease that as to, is this related to the CLL rather than everything else going on in life? We do ask about weight loss and sweats, and if we see that along with CLL, we need to think clearly and look at the lymph glands to make sure that there's not one lymph gland area that's growing more rapidly, to make us think that of the less common scenario where CLL can grow more and change to a higher grade lymphoma, which we call Richter syndrome. So our indications for treatment have not changed. So if we make a diagnosis on, incidentally, if someone comes along with a pretty otherwise unremarkable blood count, but a lymphocyte count, say, of 25, and we've sent it for cell markers and confirms a CLL phenotype, and the patient comes along to see us in clinic, and we find no enlarged lymph glands, then what do we do? And I have to say, as you will all be aware, we've been doing things very differently over the pandemic, and I think some of our patients quite like this. Certainly in terms of what we do, very much depends. When we make a diagnosis, we would generally see people at least every 3 months for a couple of visits, but then if we feel that the disease is early, stage A, and not progressing, we can gradually extend that out to 4 to 6 monthly appointments. And again, if that's stable, we have a number of people in our clinic that have a standing annual appointment, but with the stressing that if there are any concerning symptoms or new nodes, that we would see anyone back up. Over the pandemic, I'm sure that you'll all have been on the end of a telephone, and we've all been trying to muddle through the best as we can, and trying to talk through how to examine your lymph nodes, which has all been a bit of a struggle. What we tend to do for our patients who are very stable, we will offer telephone reviews if patients wish, and we are perhaps running 1 or 2 telephone reviews, but then wanting to alternate that with a face-to-face appointment at least every 2 to 3 years, just so we don't forget what we look like, and to make sure we've done a proper full examination. As I think we're all aware of the limitations of telephone appointments sometimes, but other times they can be very convenient if things are stable. We always discuss the importance, and as well as the change in the immune tolerance and risk of autoimmune complications, we know that the CLL cells manipulate the normal immune systems and the antibody responses to a number of infections infections can be impaired. So we need to stress the vigilance for promptly recognising have a lower threshold for antibiotic therapy. I could give an entire talk on COVID, which would be taking me over my 20 slides, so I'm not allowed to do that. I'm sure, hopefully, thankfully, looking that we are in a better place clearly than we were even a year ago, and certainly 2 years ago with the advent of COVID vaccinations. My arm is still recovering from my boosters on Saturday, so thankfully with the vaccinations. And one thing I wanted to highlight though is just to make sure that we have the message out there that everybody with a diagnosis of CLL should have received a letter to state that if you test positive for COVID, then you should have a link for a number for your health board to ring to be able to receive either a monoclonal antibody infusion or a 5-day course of antivirals. I know there is some discussion and some evidence as to whether the monoclonal antibodies are as effective with the Omicron variant, and my experience of my recent patients who have tested positive both with CLL and other haematological malignancies tend now to receive the antivirals, and thankfully I certainly in the last 6 months have not seen patients coming into hospital. Yes, so being aware that that additional antiviral therapy is still there in addition to the vaccination boosters that we're all being called for. If despite if we still run into problems with recurrent infections, rarely we recommend prophylactic antibiotics. And for our patients who respond poorly to routine vaccinations, then we can, and still have significant infections, we still have a number of patients where we who come along to our day unit every 4 weeks for immunoglobulin replacement of normal antibodies to protect against particularly viral infections. It's important to say, and I've got the next slide on vaccination, it's important to say that with CLL, it's important to say to avoid anyone trying to give you a live vaccine. So now that you can all travel again and might have exciting holiday plans, do check on any vaccines. And the one that is coming through is that we used to recommend not to have the shingles vaccine, but now there is the Shingrix inactivated vaccine that is available for patients between 70 and 80 years who would otherwise receive the live attenuated shingles vaccine. So there is increasing choice and availability there. And it is important to make sure that everyone's up to date with screening programmes for other malignancies, as we do know with the immune dysregulation that other cancers, particularly skin cancer. So we always recommend making sure that, say, again, if we have the chance to travel and go somewhere sunny, use a high factor sunscreen and all of that. And I have to say, over the last couple of years, I've been, myself and my colleague had made a letter running through the vaccines that are required, but I have to say I'm going to be increasingly using this. This is a snapshot of a summary record that has been produced by CLL support with forum input, and really is an excellent summary to be able to record, and also down the right hand side run through vaccinations recommended. So the annual flu vaccine, and it's important to say that for pneumococcal pneumonia vaccination, having CLL to get as effective prevention as we can do, there are 2 vaccines, one to be given 2 months before the subsequent vaccine. We've touched on the shingles vaccine, and I have to say we're all moving through and hopefully aware of and should have completed our primary course and be called for our COVID boosters. So I'm certainly going to be using this in my practice going forward. So we can run through questions on supportive management towards the end, but moving on to, if things change, if we see that there's progression, there's progressive lymphadenopathy, the lymphocyte counts going up and feeling a bit more tired and the lymph nodes are getting bigger, what do we sit down and talk about in the clinic? So it's important to talk about, and I have to say, as I'll touch on with the availability and the availability of our targeted therapies, age in itself is becoming less important. We're looking at what are the other health conditions. We consider if there's any renal dysfunction, as when we're thinking about venetoclax-based therapy, we do consider when we use it alone or with first line along with the obinutuzumab. So two very effective treatments that can break down a lot of CLL cells quickly. We worry about something called tumour lysis, where the cells can release a lot of DNA broken down, you get a lot of a rise in uric acid that can clog kidneys, and that has been a consideration. However, I have to say I have taken people with one kidney and with quite markedly impaired renal function through the current venetoclax escalation protocol, where we use the 5-week escalation from starting with a low dose with appropriate monitoring and prophylaxis. But it is one of the considerations that if I have a patient with quite severe renal impairment, it may sway me more towards thinking of a BTK inhibitor, but it's not absolutely prohibitive. It's one of the things that we look at. Similarly, we look at if there's any history of hypertension or heart failure or atrial fibrillation. As we know that BTK inhibitors, their side effect profile is slightly different, and we can see worsening of hypertension, or it would concern me if I have somebody who needs CLL therapy who has not very well controlled atrial fibrillation, particularly if they require an anticoagulant, as warfarin is contraindicated alongside BTK inhibitors. And we have a little bit of caution alongside with the newer direct oral anticoagulants used along with BTK inhibitors. The risk profile is slightly different. They're similar for the different BTK inhibitors, but there is trial evidence that the newer acalabrutinib BTK inhibitor has a slightly lower risk of atrial fibrillation or bleeding, but these are things that we're looking about and specifically considering when we're sitting down in the clinic. So I've touched on concomitant medications, so whether patients perhaps have a metal heart valve who need to be on warfarin, that would clearly sway the influence and treatment towards a venetoclax-based therapy. Whether the hypertension is well controlled, or a number of other interacting medicines that could interact. But I have to say the interacting medicines with BTK inhibitors and venetoclax are similar. Patient preference and lifestyle factors, obviously very important to think how are we going to fit treatment into life. As when we speak about BTK inhibitors at the current time, when we're speaking about monotherapy, we are speaking about continuous therapy that is started and continued either until any unacceptable side effects or until it stops working. The venetoclax-based therapies, when we use it first or second line, first line being a year, 12 months of therapy and then stopping. At second line, at relapse for 2 years and then having an end date. And I have a slide just to run through a little bit more about the starting of therapy and how that may impact on lifestyle and fit into life. And we do, and I'll touch on how we fit in the disease-related factors. So, starting, so if we're thinking about first-line treatment, our time-limited therapy being venetoclax along with obinutuzumab. And this slide, I've taken this information from the company's healthcare provider website of the scheduling of how we start. So starting venetoclax and obinutuzumab. So obinutuzumab is like rituximab but binds a slightly different site on the CD20 molecule on the B cell. So venetoclax and obinutuzumab starts with the first 3 weeks of antibody infusion. The first time we give that, we do that in hospital and we split the dose over 2 days, just because, just like venetoclax, it's an effective treatment. It can cause a lot of cell breakdown. So we do give a small test dose on day 1 and then the remainder of the dose on day 2. And sometimes we don't manage to complete the full infusion. So it may mean coming back in for the next weekly dose. So there starts off in hospital. reactions, once we've reduced the number of target cells that would bind to, become much less frequent. So subsequent therapies can be given in the day case setting, and then venetoclax starts at week 3 with and increases in dose weekly over the next 5 weeks. So the first 8 weeks of starting obinutuzumab and venetoclax means starting off in hospital, and then day case visits for at least 2 or 3 days for the blood monitoring required around that. So there's a lot more to starting therapy safely, but then as it goes on, it gets a lot easier. For month 3 to 6, it's coming up once a month for obinutuzumab and getting a month's supply of venetoclax, and then cycles 7 to 12 is just venetoclax alone, and then it can stop, which is a big deal and a nice thing to aim for, of the short-term hassle of initially starting it. To then think, if it's important to then think, I want an end date to my treatment, and then have time off treatment where I'm not going to even have to worry about potential side effects or taking treatment. Starting a BTK inhibitor, and I've put a acalabrutinib up there, but it could equally be a brutinib or any of the newer BTK inhibitors. When we can start in the outpatient setting and dispense 4 weeks of tablets. We can start on the full recommended dose, and we generally see patients a week or 2 into treatment to monitor early response and any toxicities. With that, we start at the full dose and would continue. There can be dose modification, but we generally continue until it stops working. So what does that mean in practice? So really from the outset, we're starting to think, because when I am starting to discuss treatment, I will give patients information on both unless there's a clear contraindication to one or another, and say to people that because we manage CLL still as a chronic condition, you're probably likely to have both of these types of treatment at some point, and then to talk about which order we do things in. We do, in the most cases, have options. Now we do have access for first-line venetoclax obinutuzumab for all patients in Scotland. We still do have access to first-line BTK inhibitor for all patients in Scotland, as the COVID guidance and approvals for younger patients are still in place at least until April 2023, and we'll see how the winter goes. So treatment pathways can look very different, and it is something to consider, as either following first-line venetoclax obinutuzumab will run for 12 months, and then with the aim of having a gap of a number of years before further treatment is required. Starting with first-line venetoclax obinutuzumab, when CLL comes back, we would either have the option of, if there has been a response lasting years, of using the same again, but in second line it carries on for 2 years, or going to a BTK inhibitor at that point. If we start with a BTK inhibitor, again, looking to achieve a first remission lasting a number of years. What is different is when it starts to stop working or the CLL comes back, we don't leave a gap. We will change from one to another, as if we were to stop a BTK inhibitor. Often things can progress more quickly. So it may mean moving from first line to second line treatment, and we don't leave a gap there. So I'm not sure how useful this cartoon I sketched out is, but it's just to try and get a visual representation of what a treatment pathway might look like. What's the best treatment? In terms of, and as I've said, we have I'm not going to cover all of the trials today. Key trials that have been updated that it's worth speaking about are the updated 5-year follow-up data from the CLL14 study, which was conducted comparing the comparator arm of obinutuzumab and chlorambucil against the 12-month venetoclax with obinutuzumab. And we can see now that with 5 years of follow-up, that at 5 years, 63% of patients remain in remission, which is really quite remarkable, and significantly superior to the treatment that we were using as standard just until 2 or 3 years ago. And at that point, for the initial onboarding in the first 8 weeks, that 5 years from then, that only 1 in 8 patients are needing a second line of therapy, which is a really attractive treatment. There's a lot of discussion in the BSH guidelines as to how, and getting down to questions about what about my mutation status, and there's discussion as to whether time-limited therapies particularly benefit patients with mutated or unmutated IGVH, and this is the graph coming down here. So we can see this blue line, the dotted dashed blue line are patients with a mutated IGVH who do seem to do particularly well with time-limited therapy. And then that leads to discussion about what about patients with an unmutated IGVH who look on this graph to progress at an earlier point. Now, I had the opportunity of presenting at a meeting alongside Othman Al-Sawaf, who's involved in the CLL study, CLL14 trial, and spoke to this data, and he ran through looking at these results. They went on to pick out and do what we call multivariate analysis to try and look at independent prognostic factors to see whether what came out, and the only prognostic factors that came out for a shorter duration of response was having a P53 mutation or deletion and bulk disease. So immunoglobulin and heavy chain mutation status itself, when it was picked out from the other factors, didn't actually come out as an independent prognostic variable. And even looking at this curve here, we can see that compared to the cladambacillin obinutuzumab arm, this is still significantly superior. So certainly I wouldn't limit discussing time-limited therapy to patients with a mutated IGVH gene, and I think very much it's a lot more nuanced, and we need to look at all of the factors to make the right decision for an individual patient. Other trials that have reported at this year's European Haematology meeting in the summer were also 5-year data from the Elevate treatment naive trial, and what is licensed for use in Scotland. We are looking at the green line here. We do not have approval to use acalabrutinib in combination with obinutuzumab. This study was not powered to really fully assess whether the combination were superior, but we do have approval for acalabrutinib monotherapy, and we see again a significant improvement over historical chemoimmunotherapy, and at the 5-year time point, 72% of patients remaining in remission. And there is, when I don't have the mutation status curves here, but there is really minimal difference between mutated and unmutated IGVH. So really the bottom line is both are very effective first-line therapies, and we need to consider really all of the factors we've spoken about. Now, why are we speaking about CLL13? So you could ask me, what about the place of, should I think about FCR, and how does time-limited targeted therapy stack up against chemoimmunotherapy in the younger patients who we would have historically treated with FCR. So that has been assessed in the CLL13 or GAIA trial, which used a chemoimmunotherapy backbone of either FCR or bendamustine rituximab. So it's not a pure FCR trial, but the majority of patients were treated with FCR, and the experimental arms were either using 12 months of venetoclax along with rituximab, or along with obinutuzumab, or actually the triplet combination of ibrutinib, venetoclax and obinutuzumab. But I'll highlight really on the arms looking at how chemoimmunotherapy compares to the time-limited venetoclax and obinutuzumab. Now, in May of this year, when the SMC approved venetoclax obinutuzumab for routine use in Scotland, that was actually approved really on the early results of looking at low-level or eradication of what we call minimal residual disease in the blood and bone marrow, and prior to these results coming out in the summer, the trial had already demonstrated higher rates of clearing low-level residual disease in the venetoclax obinutuzumab arm than the chemoimmunotherapy arm, and that underpinned the approval by the SMC. And it was actually a bit surprising that these follow-up data looking at progression-free survival or remission length came out as a late-breaking abstract in the European meeting in June. So we can see that the chemoimmunotherapy arm is in blue, and we have the venetoclax along with obinutuzumab arm in red, seeing a superior. This is at three-year progression-free survival of chemoimmunotherapy at just around 75%, and a significant improvement with venetoclax obinutuzumab. You could ask me, does that vary between mutation, IGVH mutation status? And breaking this down, we can see that the separation of the curves is greater for patients with an unmutated IGHV, where targeted therapy does seem significantly superior. There's a little bit more discussion here for patients with mutated IGHV, as the curves are closer together, with the 3-year survival at 89 versus 93%. So you could ask, well, does FCR remain an acceptable treatment? It is in the BSH guidelines. I've recently, and attending the recent CLL forum meeting, I had investigators on the CLL 13 trial starting to speak about other parameters that were assessed. Things like, obviously, trial safety. Safety is paramount in any trial, and looking at things like second primary malignancies, which have been found to be higher in patients treated with chemoimmunotherapy than with the venetoclax-based therapy, and also looking at when the CLL comes back. As we know, this is not curative therapy, that patients treated with chemoimmunotherapy tend to have more genetic mutations that could then lead to treatment resistance. So I think, considering all of these factors, I think my personal view, and I will put my hand up and state this as a personal view since FCR remains in the BSH guidance, so I should be stating that quite clearly, that it's my personal view that I'm finding it more and more difficult if a patient will say to me, I really want FCR, I've got mutated IGHV, I've heard about these long-term remissions. I mean, clearly we don't have the long-term follow-up on venetoclax obinutuzumab or the other targeted combinations against chemoimmunotherapy. However, on the early data, knowing that we have increased rates of MRD clearance, and knowing that MRD clearance for a number of therapies does tend to correlate with progression-free survival, I think we have reason to be optimistic that the long-term follow-up data may, well, they will be what they will be, but I am optimistic that they may continue in favour of targeted therapies. So in my practice, I have not prescribed FCR in the last 4 years, which is not to say that it is definitely an incorrect thing to do. It does remain in the guidelines, but restricted to our patients with mutated IGHV. You may ask me, but I have a TP53 deletion. What does that mean? Is one or other approach better? I guess we have probably more data on BTK inhibitor therapy from the earlier ibrutinib P53 deleted cohort trials, and then more recently looking at patients with a TP53 deletion treated within the Elevate treatment naive trial, and we can see 5-year progression-free survival on acalabrutinib in over 70%. When we look at the CLL14 study, we do know that patients with a P53 mutation will tend to progress more rapidly than patients without, treated with 12 months of venetoclax obinutuzumab. However, at 5 years from initial treatment, 40% of patients will remain in remission. So there is much discussion as to whether all patients with a P53 deletion should be advised to start a BTK inhibitor, and I'm more than happy to discuss this. I think my personal view is that both are very reasonable treatment options, as we know that venetoclax obinutuzumab is only a first-line authorised approved combination, and is significantly superior to what we used before, and still has a 40% chance of remaining in remission at 5 years, and then you still have your BTK inhibitor up your sleeve. So I think really in all situations, what I'm trying to say is my personal view is that we need to be considering lifestyle factors, comorbidities, and patient preference, and we have options. What about when CLL comes back? I think it is now widely accepted that chemoimmunotherapy is no longer recommended as an option at the time of relapse. With the last iteration of the guidelines, there was a time-limited therapy that if a relapse was later, after 4 or 5 years, we could consider retreatment with chemoimmunotherapy. However, if CLL comes back within 2 or 3 years, we should be looking at a targeted therapy, but that is now really gone with the wealth of trials comparing targeted agents to chemoimmunotherapy at relapse. So that's an important point. Treatment choice at relapse is obviously guided by previous therapy and duration of response. If we see relapse on a BTK inhibitor at the current point of time, we would change and switch to Venetoclax-based therapy, and to do that with minimal gap, or indeed sometimes an overlap, whilst we go through Venetoclax dose escalation to ensure continued effective therapy. For patients who've started on fixed duration Venetoclax-based therapy, there is a choice at relapse either to go to a BTK inhibitor, or if there has been a long period of remission, and there's ongoing debate as to how long is long. I think it's generally accepted that a remission lasting 12 to 18 months is minimal, where we may think that it may be appropriate to retreat with Venetoclax, as we do know that patients initially responding to Venetoclax-based therapy, the majority will respond again, as long as we have seen a durable period of remission. So again, we have options, and for patients, and about 4 in 10 patients on ibrutinib would stop treatment due to side effects. In that case, there may be a period, if patients stop treatment who are due to toxicity, who are in a good remission. Typically, we may see at least 18 months to a couple of years before needing further therapy, and now we do have options of either Venetoclax, or some patients intolerant to ibrutinib may tolerate acalabrutinib. And again, as I drew this cartoon, I've put it up again just to really remind everybody of how that might look, and just starting to be thinking not only of what I do now, but how that might play out to what I may do in the longer term. So future developments, I just have a couple of slides, and then I think I will be out of time as to what is coming round the corner. And many of you listening today may have actually participated both either in the FLAIR trial or the GLOW trial, which has arms looking at the combination of a BTK inhibitor along with Venetoclax, and we are now starting to see very encouraging results. We know from the CLARITY trial, which first assessed combination therapy in the relapse setting, that this is tolerable and feasible, but how about in the first line setting? So the GLOW study looked at generally older patients with comorbidities, comparing a time-limited 3-month roll-in with ibrutinib followed by 12-month combination ibrutinib-Venetoclax against the comparator of chlorambucil with obinutuzumab, and that is fairly clear to see that we have much more durable remissions following the combination arm. Also, an American study called the CAPTIVATE study looking particularly at younger patients with some high-risk features, whether it was unmutated IGHV or P53 mutation or deletion, seeing very encouraging, very high rates of both complete disease remission measured on bone marrow and CT, and indeed MRD clearance, and indeed the FLAIR trial, which is continuing to report results, and has very recently at the European meeting in the summer reported MRD clearance rates on the ibrutinib venetoclax arm, which are really very encouraging, particularly in IgH unmutated patients and patients, for example, with an 11q deletion. So the combination is currently being considered by NICE, and we await, I don't have a date as to when that will be ruled upon. The BSH guidelines do discuss the increase in early infections and do make a statement to suggest that they would generally recommend combination therapy in patients with fewer comorbidities with higher risk CLL. But we will wait to see how this, how the review and approvals come through. But this may well be an additional choice we may have going forward in the first line setting. Now, another question is, and I've spoken about the therapies we do have and the fact that none are curative. What do we do? And I think it's clear that now, compared to 5 and 10 years ago, our areas of unmet need are shrinking but have not gone away, because we know that mutations can arise in CLL cells, both that mean that either venetoclax or BTK inhibitors will not work. So another drug that is coming through showing really very exciting promise is pirtobrutinib, which is another BTK inhibitor, but it works in a slightly different way. It's got a different type of, binds in a different way and to a different site on the BTK protein than other BTK inhibitors. And in patients who have developed the most common mutation accounting for ibrutinib or acalabrutinib resistance, the pirtobrutinib can still bind and inhibit the activity of BTK. It's been assessed in the phase 1 and 2 Bruin trial, which looked at a range of relapsed and refractory B-cell malignancies, including CLL, included a large number of patients with relapsed CLL who had the majority of patients had multiple prior lines of therapy, including previous BTK inhibitor therapy. The recommended dosing to take forward is 200 milligrams once daily, and showing really very encouraging response rates in heavily pretreated patients, even in patients with Richter's transformation, which remains very challenging to manage. So there is now an early access scheme. It is not licensed for routine and approved for routine use in the UK. However, there is an early access scheme available for 2 criteria, either for management of CLL, where the CLL is refractory to all of our available lines of therapy, which means chemotherapy and monoclonal antibody, BTK inhibitor, BCL2 inhibitor, and a PI3 kinase inhibitor. We obviously don't use much idelalisib at the current time due to the side effect profile, but it is a requirement for treatment with pirtobrutinib through the scheme. Also for patients with Richter's transformation who have had prior therapy for Richter's, so that is available. So just as a and I have been able to go through and work through and access treatment through that scheme. So I think this is the trial data will be very encouraging to watch in years to come and to see where approvals may come. So I think I'm probably a little over time and will sum up there. So really, in summary, for many people living with CLL, I think, as you've all heard this morning, that being able to live well with CLL, but treatment's not always indicated, and that active surveillance and supportive care is still the backbone for management for a large number of people living with CLL. Where active treatment is indicated, chemoimmunotherapy has been almost completely replaced by targeted therapy, reflected in the updated BSH guideline, and I've expressed my own opinions on how I interpret the data. At most treatment decision points, there are options between targeted therapies. In terms of sequencing, we don't have any clear data that in the long term that any particular sequence is more favourable than another. That may change with time, and clearly treatment planning involves a lot of education at an early point, and there's usually enough time to be able to be checking the prognostic tests at the same time as discussing treatment options and then putting everything together to make the right treatment decision. at each stage, and clearly from the last couple of slides, it is likely that our treatment pathways are going to continue to change and develop as any new approvals come through. So I think I'll stop there, and thank you all for listening through, and I'll be happy to discuss.